Hi guys, good evening. I hope I'm audible, I'm visible. This is our third set of the compounding series. So we will be discussing question number 15 to question number 21. If you have any questions, any queries, you know how to reach out to us, and any suggestions, they are going to be absolutely welcome. We'll start with the first question. I'm going to dig into the question which was asked on day 15. The question that was asked on day 15 is a 23-year-old patient presented with fever, weight loss, gives a history of blood in stool and vomiting. On examination, there's a right hypochondriac tenderness and there's hepatomegaly. Also, was that the left lobe of the liver with the heterogeneous density, ragged edges, and multiple septations. What is the most likely diagnosis? So the options that you have here, they're asking you to choose between the pyogenic liver abscess, hydrated cyst, amoebic liver abscess, hepatocellular cancer. I can rule out HCC by a simple fact that it is not in that age. Okay, so you can just leave across. Nothing is. We see HCC is going to predominantly present to you as an incidental finding or a mass. Apart from that, nothing more spectacular about it. Now, I need to understand that when you have a patient, you are going to be in, right. See, look across here. I need to know whether you're talking about the pyogenic liver abscess, are you talking about the amoebic liver abscess, or are you talking about the high, right? So when you look at all these three presentations, first thing that you will see is going to be the organism. When you talk about the organisms that are associated for pyogenic liver abscess, it's caused by bacteria. Other two, that is your amoebic liver abscess and the hydrated cyst, they are caused by the parasite. Right? Both of them are caused by the. You say what is the most common causative agent? Most common causative agent. Here, this is going to be E. coli. Here it is going to be entamoeba. Here it is going to be. So how does this organism reach the liver? So route of infection. When we talk about the route of infection, these bacteria usually follow an ascending route of infection. Usually when there's a CBD obstruction, then only they can reach down to the liver. So it is usually via the bile duct. Most common is via the bile duct. If it is not there, then it is via the not portal vein, then it is hepatic artery. Not hepatic artery, the last one is direct route. Right. Whereas amoebic liver abscess, initially it is going to enter into the body as fecal-oral route of contamination. When it goes the fecal-oral route of contamination, go into the cecum, result in flash-shaped ulcer and result in amoebic colitis. Once it is formed the amoebic colitis, from there it is going to enter in portal circulation. That is via the portal vein. The infected stage is tetranucleate cyst. It is going to go into the liver, and there it is going to develop into amoebic liver. Echinococcus granulosus is going to be because of ingestion of meat which is infested with the hydrated cyst. It goes via the portal circulation into the liver. It enters into the portal circulation via the. So within the liver, if they ask you what is the most common site, the most common site within the liver for all of them, it is going to be your right side, called as the right hemisphere. All these is going to be right side of right. It is going to be the right hemisphere. Is there any specific risk factors that you can attribute? Now, when you talk about the risk factors for pyogenic liver abscess is alcohol as well as here it is only alcohol. There is no specific risk factors in your or hydrated or the. Now, when they enter the that are going to be present, remember amoebic liver abscess, they use multiple. Amoebic liver abscess, they use multiples. Parasites are used. They're usually when you talk about the age of presentation, sex and talk about age, your pyogenic liver abscess about 50 more common. It is seen between the younger age group, that is 20 years. Again, it is more common in male, whereas it can be seen 40 the hydrated cyst is 40 to. How do they present to you in terms of clinical present? They will have all the features of the infection or the inflammation of the liver. That rubercaloid tumor will be right hypochondriac pain. They'll have all the same features. There is presence of right hypochondriac pain. There is right hypochondriac right hypochondriac there'll be fever. But along with that, what else do you have to tell you that it is your pyogenic liver abscess? They usually have obstructive because they have jaundice. Remember, the most common abnormality that you will see to be elevated alkaline is AL will be elevated. Your pyogenic liver abscess. So pyogenic liver abscess PLA, you do reverse of it. Reverse will become ALP. So ALP is elevated in this. All these features which are said will also be present. Amoebic liver abscess, there is no jaundice in place. Jaundice, so they will have history of colitis. Here they are usually so they're usually asymptomatic when it comes to the clinical presentation of hydrated incidental finding, right? Investigation is going to be with respect to triple phase CT or CCT or all three of them. But if you talk about the confirmation, pyogenic liver abscess, because there's bacteria, you can culture it. The other two, you have to go with ELISA because they're parasites, you cannot culture. Management for pyogenic liver abscess, you have to go with the USG guide aspiration with antibiotics. Whereas your amoebic liver abscess, high dose metronidazole, and your hydrated cyst is going to be your pair therapy, that is percutaneous aspiration, installation of scolicidal agent, and reaspiration. Do not forget about it. So when you look at the question, you had a patient with blood in stools. There is fever, weight loss, blood in stools, vomiting. All that indicate GI features. GI features is a C colitis. Here you can see colitis. Right? So again, look at the which is also in favor of amoebic liver abscess. Colitis is there. Patient have the features of infections to the liver. There is heterogeneous lesion, and there are, see, when they say multiple septations, they're not seeing multiple. They're not talking about multiple lesions. There's a multiple septations in a single lesion. Again, a characteristic of your parasitic lesion. So here the answer is going to be amoebic liver abscess. The answer to this question is our amoebic abscess, that is C. Right? That's your question number 1. That is day 15. That's the answer that you have. Going to day 16. Now, day 16 is a pretty straightforward question. A repeat exam question. What does it say? The following test is done before performing an EVA. Before performing the procedure, identify. You're trying to touch both radial and ulnar artery to see the patency of both the flow, and this is what we call as the Allen's test. Allen's test is done. Allen's test is performed to look for the patency of the palmar arches, and if they are only patent, then only you'll go with AV fistula. Otherwise, you will not do so. Right? Adson's-Roos test is for your thoracic outlet syndrome, which we'll discuss in detail in our next. Going to day 17. Now, this is something that been asked again and again. So, run through. Cannot go to the exam without talking about or without knowing your appendix chapter. Right? If you're going to the exam without reading your appendix, that means you're creating a blunder. The appendix is something that is expected of you to. Right? Now, when you talk about the positions of the appendix, this so the following position you have to match it. I think match the right, and they have numbered it here. So we'll try to answer them. What is the first number that you have? This is behind the cecum, so this is what we call it as retrocecal. In fact, 74% of your appendixes are retrocecal. This is the most common position that you will see. Now, see position number 2, it is going to be under surface of the cecum, and this is what we call it as paracecal. So paracecal, 2% of your entire appendix paracecal. Next, you have just under this, you have subcecal also. If it is pointing towards the pelvis, I can say this pelvic in position. This pelvic in. So this can be a paracecal. I would correction. If the appendix is running like just hugging just hugging this, then I would say it is paracecal. Then I would say paracecal. Just under the cecum, we call it a subcecal. Subcecal is even more less 1.5%. Pelvic input is going to be 21%. Now there is in front of the ileum, that is what we call it as ileal, and one that is behind the ileum is what we call it as pre-ileal. And when you look at this, the pre-ileal accounts for approximately 1%. The post-ileal is going to 5%. So if you look at all the entire extent, the least common variety is going to be post-ileal, which is going to be 0.5%. The most common is going to be retrocecal in position. So when you look at this, we are subcecal. Where do you have subcecal? Subcecal is going to be 2. Going to be 2. Retrocecal is going to be 1. So inside the pelvis is going to be. Talk about paracecal. Paracecal position does not exist purely here. So it is 4 is pre-ileal. Do we have ileal here? I think the paracecal has to be pre-ileal because something to be pre-ileal. Fourth position is going to be pre-ileal. So A is going to be 2. 1 is B, that is for sure. 2 is going to be A. Write it here. 1 is B. 2 is going to be 1 is 2 is going to be subcecal only. Subcecal is what? A. Pointing towards the pelvis. And the fourth one, that is going to be a pre-ileal position. It is 1B. I think the options which are messed up. This is the correct option, guys. Make sure you take right. This is the position that you have to follow. Going to day 80. Which of the following statement is true about it is the most common neoplasm of the. You're looking for the true statement, most common one. Remember, it is the most common benign tumor. Okay, let's see which of the following can be a wrong state. The most common posterior, no, it is an anterior mediastinal tumor. So the option usually symptomatic with dyspnea, dysphagia, and see when they present become when they become symptomatic, they have dyspnea, they will have dysphagia, they will have sphasis syndrome, but usually they are associated with myasthenia gravis, right? So it is not symptomatic. They are usually associated with myasthenia. Them present to you with myasthenia, right state. Chest X-ray is the investigation of choice. No, it is going to be CT. The only thing I can say, it is the most common mediastinal tumor. Overall, the most common neoplasm of the thymus is the thymoma. Absolutely. Answer here is going for, that's a day 18. Going to day 19. Again, a very repeat exam question. Tired answering this thing. Which of the following is considered to be the best method to localize the parathyroid adenoma? It is going to be system scan. What system scan? Again, a repeat question. It to be a SPECT system scan. Remember, USG of the neck is the screening. Okay, 4D CT is going to be the gold standard. If they say, what is the go? So we say there are certain questions that you need to know. Investigation of choice. Investigate for primary hyperparathyroidism. Primary hyperparathyroidism or but if I say what is the best in gold standard of right? So two things that you have to remember. So here it is going to be SISTA maybe. Question number 20 again, previous exam question. spectacular. All these are your ionized. Again. Which classification of the bile duct injury, your day 20 that you have? Which classific which classification bile duct injury to account both vascular and the location of injury? Remember, the only classification that takes both into consideration is right. When you talk about Strasbourg, it bile duct injury talks about bile duct. Bismuth is about stricture, about your bile duct. The one that consider both vascular as well as the location of the injury is going to be Hanover. Answer here is going to be question number 21. Again, this is a question that is expected again and again for our exam, that what is going to be a open cardiac massage classified as. So when you talk about a clean wound, again, let's look at the criteria that are mentioned. Talk about the clean wound. The criteria for a clean, number one, it should be non-traumatic. Be non it should be non should be an elective surgery, and there should be no into all your examples that you have is your brain surgeries, your joint surgeries, your thyroidectomy, your mastectomies. Everywhere you're not entering into nasal cavity, lipoma excision, your inguinal hernia, which is where you're not opening up the sacs and all those are considered to be as your clean surgery. Now, when you have clean contaminated surgery, what are clean contaminated? The criteria for a clean contaminated surgery. For a clean contaminated surgery, again, be on should be an elective, and here we can accept entry will entry into the cavity under controlled environment. The controlled environment, that is, it's not emergency. Now, all these are going to be uncomplicated appendicectomy, uncomplicated cholecystectomy, elective gastric surgeries, elective bowel surgeries. All these are considered to be your TAP, that is transabdominal preperitoneal repair, your TEP, that is, sorry, your IPOM, that is intraperitoneal only mesh repairs, where you are putting inside the abdominal cavity and doing so. All these will be considered to be as your clean contaminated wound. Is going to be clean contaminated wounds, right? When you talk about dirty wounds are considered to be number one, traumatic. These are your traumatic wounds. These are your emergency surgeries. All your re-explorations. All your re-explorations. So there will be traumatic, emergency, re-explorations. Re-explorations will be considered to be as contaminated. Dirty is quite simple if it consists of pus or fecal matter. If pus or feces are present, it will become dirty. Now, when you look at the open cardiac massage, right, an open cardiac massage is an emergency procedure. It is an emergency procedure. Now, because it is an emergency procedure, I cannot say it is clean. We just learned it cannot be a clean. And again, it cannot be clean contaminated because it is elective. So both of them has to be elective. To call it as a clean or a clean contaminated, the criteria itself says that these has to be an elective surgery. Okay. Now we have eliminated these two. We're left with contaminated dirty. The only criteria for dirty is there has to be pus or feces. In open cardiac massage, there is neither pus nor feces. So this is also out of the options. The best answer here is going to be a contaminated wound. So here it is going to be B for Bombay. So answer here is B for Bombay, right? So this was your third set of the compounding series. So we have covered 21 questions of your previous INI CT with a crisp explanation and correct answers. Do watch them on a repeat basis just before the exam. It is just going to give you an additional boost, right? So that's it for today from the compounding series. We try to keep it close, short, crisp. See you again next week with another questions. That is going to be from question number 22 to question number 28. Right. Until then, thank you so much. Hi, Dhruv. Thank you for joining. If you have any questions, any queries, you know where to reach out. You'll find the PDF in our group that is going to be on the Telegram as well as on the Instagram. It is the surgery guy. It is the surgery guy by my name. It is your Dr. Sandeep. Until then, thank you so much for joining. Next week. Bye bye.